My name is Rebecca Fitzgerald, and I'm a clinical gastroenterologist at Addenbrooke's Hospital in Cambridge in the UK, and I lead a research programme on esophageal and gastric cancer at the MRC Cancer Unit at the University of Cambridge. I'm going to discuss our study, which is entitled Prospective Cohort Study, Assessing Outcomes of Patients from Families Fulfilling Criteria for Hereditary Diffuse Gastric Cancer Undergoing Endoscopic Surveillance. This was performed in Cambridge and also in collaboration with Chris Raghunath, who's an endoscopist and researcher from the University of Nottingham. Let me give some brief background about this condition first, and then explain why we conducted the study and what I think the clinical implications are. So hereditary diffuse gastric cancer is rare. It accounts for 1 to 3% of all gastric cancers. And in patients fulfilling the clinical criteria for this condition, around 25 to 50% of them will have a germline mutation in the ectoterin gene called CDH1. Individuals who inherit a CDH1 mutation have about an 80% lifetime risk of developing multifocal diffuse gastric cancer at an average age of around 40. And therefore, in these patients, prophylactic gastrectomy is generally recommended. However, as you can imagine, deciding whether and when to have a gastrectomy when you're young and healthy is a huge decision, affected by concerns over loss of earnings, quality of life, and childbearing considerations for women. And therefore, in our experience, it's not uncommon for patients to opt for endoscopic surveillance in the first instance. In addition, there are those families who are waiting for results of genetic testing who want to have surveillance. There are those families in whom the causative mutation is uncertain or unknown. For example, a missense mutation in CDH1, which is of unknown pathogenicity. Or perhaps no mutation has been found by genetic screening of the CDH1 gene in that family. So therefore, we set about studying the efficacy and safety of surveillance in the context of hereditary diffuse gastric cancer prospectively. We also wanted to look at whether trimodal imaging, that's using the Olympus ETMI scope, with white light high resolution combined with autofluorescence and narrowband imaging, could increase the yield of detecting foci of clinically silent signet ring cancer cells. In the past, papers describing the yield of endoscopic detection of such foci was rather low, and there's been concern, therefore, about endoscopic surveillance as a method for monitoring these patients. Our study then involved 29 patients from 17 families who participated in 70 endoscopies overall. We used a strict protocol. It involved an acetylcysteine drink first to remove any mucus prior to the procedure, biopsy of any focal lesions, including those detected by ETMI, and then 24 random biopsies covering each anatomical area in turn. So let's now go to the results. In patients with a known CDH1 mutation, surveillance endoscopy picked up microscopic foci in more than half, 9 out of 14 of the patients. There were 8 patients in whom the CDH1 mutation status was unknown at the start of the study. We found lesions in 5 of these patients, and they all subsequently had a germline mutation identified. Now, of the 3 of the 8 patients in whom no lesions were identified, 1 was found to have a whole gene deletion of CDH1, and in this family, all the cancers have been lobular breast rather than gastric. In the absence of signet ring cell foci in these 3 out of 8 patients, so we didn't find any lesions, but they were all found later to have a mutation. They've all opted to continue endoscopic surveillance rather than have a gastrectomy. There were another 7 patients with no evidence of CDH1 mutation in the family. These patients would not therefore normally be offered a prophylactic gastrectomy. 2 siblings within this group had lesions found at endoscopy. So this then gave us the phenotype. This confirmed their susceptibility, and as a result, they were offered a gastrectomy, which they both accepted, and multiple foci of signet ring cells were found in the gastrectomy specimen. So overall then, when lesions were found, this did help a number of patients to make a clinical decision to have a gastrectomy. However, there were some patients who preferred still to delay surgery for as long as possible, and we discussed these at length in the paper. One such patient with a germline mutation with lesions found went on to develop stage 4 disease despite frequent endoscopy in the absence of symptoms. Hence, we think that there is great caution that needs to be exercised in these patients So again, who have a mutation, who have microscopic foci, who want to delay surgery because they may really be at high risk. With regards to the type of endoscopy performed, the additional use of the trimodal imaging targeting biopsies identified a further 3 cases. In other words, identified a further 3 cases with microscopic foci of signet ring cells. However, the technique had very poor specificity. In our experience, the other important thing to mention is working with expert pathologists to identify these very tiny, subtle microscopic foci is essential as part of the endoscopic program. So what have we learned? Well, endoscopy with multiple biopsies and close liaison with pathologists does, in our experience, have an important role to play in guiding the timing of prophylactic gastrectomy, particularly for those in whom the mutation status is uncertain or unknown at that time, and for those reluctant to proceed straight to prophylactic gastrectomy. As an aside, I'd also remind us all not to forget to take a family history in any patient presenting with diffuse type gastric cancer. And if you're interested in what the quality of life is in patients undergoing prophylactic gastrectomy, we've recently reported this in the Annals of Surgery. Thank you very much for listening.